Good morning. It's my pleasure to introduce our next speaker and thank him for leaving beautiful San Diego to visit us in what is a fairly nice weekend here in Pittsburgh. I'm speaking about Dr. Laith Alshawabkeh. He is an associate professor of medicine at University of California at San Diego and is the director of their adult congenital heart disease program.
Thank you so much, everybody in the organizing committee, for inviting me here. I was talking earlier with someone that we haven't seen the sun in San Diego in 2 months. So I got my tan this morning walking over. So today I will focus the conversation about transcatheter edge-to-edge repair with a clip system of the atrioventricular valves in patients with the Fontan-Kreutzer circulation. Many of you have talked, and Dr. Goldstein eloquently described the data with rest and exercise, with the differences between the Fontan and the regular circulation. But moving forward to the Fontan hemodynamics, remember that the left atrial pressure is just one step before the LV EDP, or the single ventricle EDP, and the combination of these two might determine the cardiac output and oxygen delivery for a lot of these patients, and therefore systemic atrioventricular valve regurgitation is critical in long-term survival for these patients. This is data from Tariq that he published a few years ago, showing that severe or moderate systemic atrioventricular valve regurgitation was the strongest predictor of mortality in these patients. And I really like this paper because he lumped the ventricular dysfunction and AV valve regurgitation. And that's reflective of our inability sometimes to tease out the true underlying ventricular function in patients with severe AV valve regurgitation in Fontan and other circulations as well. But before embarking on any intervention for our patients, it's important to emphasize that this is a multidisciplinary conversation. And before putting a patient on the cath table, you have to really make sure that all the stakeholders have had a chance to review the primary data and weighed in multidisciplinary open forum. But importantly, the committee has to conclude that this particular intervention is most likely to result in benefit to this patient. So with that in mind, I will go over a few cases. This was early on in our experience. This patient was born with complex cyanotic congenital heart disease. She had crisscross AV valves, hypoplastic tricuspid, and left-sided morphologic right ventricle. And she lived all her life across the border in Mexico and presented in late 30s and underwent a percutaneous Glenn anastomosis due to profound cyanosis. And that gave her a lot of stability for about 4 or 5 years until she presented now with significant worsening of her functional class, this time due to severe mitral regurgitation. It's important in this particular anatomy to remember that the course of the catheter will depend a lot on the relationship between the inner atrial septum and also the atrioventricular valve. And in this particular patient, that was very challenging. You do need an anchor for the guide catheter when you're crossing the inner atrial septum, so you can't really utilize, most of the time, you can't utilize a pre-existing atrial septal defect. So this is her intra-procedural TEE. And again, you appreciate the crisscross relationship of the AV valves. This is the hypoplastic tricuspid valve. You're seeing it on FOS. And this is the mitral valve. So before, obviously, these patients go to the cath lab, we do a detailed TEE. And this particular patient didn't really have dysplasia of the mitral valve. It was of normal morphology. But what you see is that there's tethering of the posterior leaflet, and there is some prolapse of the anterior leaflet, culminating in severe mitral regurgitation. In these complex patients, sometimes we do 3D modeling and even mock procedure. And for this patient, we concluded that the ASD was really in an unfavorable location. You have to cross the septum natively. So coming up from the IVC, above the tricuspid valve and far away from the ASD was our point of entry to achieve sufficient height for the guide system to cross, and also for the clip delivery system to straddle the valve. So this is the ASD here, and this is the guide crossing the inner atrial septum, and this is after 5 hours. And you see here the clip has basically caught on the anterior and the posterior leaflets in the, you can call it A2, P2 position, and creating a double orifice valve and reducing the regurgitation to a mild to moderate degree. So this patient improved her functional class and was able to regain her functional capacity. It is interesting sometimes in some of these patients, while there are many, many challenges, there are also opportunities. In a usual anatomy, sometimes it's a balance between how much regurgitation reduction you achieve versus stenosis of the valve that you cause. In patients who have 2 inlets of AV valves, you can actually be fairly aggressive in clipping the AV valve in those patients. The second case was a 15-year-old male, really sick, heterotaxy, unbalanced RV dominant AV canal, had repair palliated to an extracardiac Fontan-Kreutzer in childhood, and presented really late, unfortunately, with failing Fontan, cardiogenic shock, on milrinone, transfer to our center from out of state for consideration of transplantation. When he presented to the hospital, he was in dire straits, and he was on multiple inotropes and barely able to breathe, even sitting up. And it was a decision between whether ECMO or try to achieve some type of a bridge by reducing the AV valve regurgitation until he is able to get transplanted. So this is his transthoracic echo. And as you can see, the systemic atrioventricular valve is just wide open. You might grade it as torrential. And in those patients, unless you have a hyperdynamic ventricle, this ventricle is really, really sick. So you have to kind of remember that. And you can see here, there's a very large coaptation gap between the leaflets, really across all commissures, traversing both sides of the ventricle. Okay, how do you get out of this? And now, for this procedure, we were able to cross the extracardiac conduit somewhat in similar fashion to usual anatomy, and we were able to achieve enough height above the AV valve to straddle and then introduce the clip across the valve. And in earlier experience, even with the usual anatomy mitral clip system, there are some contraindications regarding how big of a coaptation gap you can tolerate. But with the second and even newer generation clip systems that are wider, that are less likely to cause tearing of the valve or injury to the valve itself, you really, if you're able to capture both leaflets adequately within the clip arms, you should be safe. And in this patient, we're able to reduce his torrential AV valve regurgitation to now severe. What's not shown here is that the left atrial pressure at the beginning of the case was about 30, with V waves up to 60. And once one clip was positioned, the V waves dropped to 30, and the mean pressure was around 15 to 20. And at that point, due to severe systemic ventricular dysfunction, we decided to stop and not proceed further. And basically, we've achieved our objective to bridge this patient who underwent successful transplantation. This is the last case. This patient was 23 years old, double outlet right ventricle, complete AV canal, mitral atresia, palliated to a lateral tunnel Obviously, what Dr. Goldstein had discussed earlier, this patient developed very early Fontan pathway stenosis and underwent a stent that was later restented due to fracture of the Fontan stent. And he came to us with failing circulation due to severe TR, but also had moderate RV dysfunction. It was functional class 3, really limited, inching to 4. Unfortunately, not a candidate for transplantation due to overwhelming social challenges with his family. So the decision of the committee was to proceed with transcatheter edge-to-edge repair and see if we were able to reduce his regurgitation. The challenge was presence of 2 overlapping stents within the Fontan conduit. So really it wasn't an option to go in the usual pathway across the Fontan. And what we ended up doing was going from the right-sided glen, and which happened to be in close proximity to the roof of the atrium in a straight shot. And we were able to land the clip immediately above the valve from the neck of the patient. And what you see here, this is the stent in the Fontan, which is left-sided. And also we used IVUS at the same time, or ICE, intracardiac echo, to be able to visualize tenting of this catheter across the atrium. And what you see here, you see the clip arms open as it's below the valve, attempting to capture the leaflets within the clip arms guided by TEE. And you see a similar picture here in TEE, traversing the roof of the atrium, straddling the valve, and finally we're able to capture the leaflets with 1 clip, and which was deployed. And here you see double orifice, really good tissue bridge, and that reduced the regurgitation, but he continued to have significant regurgitation, so we needed to deploy a second clip immediately lateral to that first clip, which was deployed successfully intraprocedurally here. And his regurgitation was reduced to mild to moderate. However, on next day follow-up, we noted that that second clip had detached from one of the leaflets, but remained fairly well anchored to the other leaflet. So that's what we call single leaflet detachment. And his TR was in the moderate range, but due to functional improvement for the patient, we just continued active surveillance and did not do any further interventions at this point in time. So our experience, we've done about 15 cases, adults with congenital heart disease, 4 with single ventricle, and for the large majority, we were able to reduce AV valve severity, regurgitation severity after the procedure. And there has been some significant improvement in New York Heart Association functional class. We are actually submitting our data and pooling it with another center. Together, we will have more than 30 cases, so it should be coming out soon. From our experience, also, we've learned that for a lot of these patients, the thinking of considering advanced therapies or similar interventions sometimes is late, and you just have to kind of raise awareness and availability of this technology for these patients. Valve anatomy is paramount. You can't just deploy a clip in any valve. You really have to study the valve carefully for adequacy. And if it's a candidate, then most likely you should be able to deploy the clip. Puncturing the baffle could be challenging, and you have to be creative in finding alternate access. At the end of the day, really, most of the work that we do before the cath and during the procedure has to do with positioning, where you exactly cross and introduce the delivery system. That is going to be probably the most important part of the procedure, not the deployment of the clip, because that positions you well in capturing the leaflets in their entirety and not have single leaflet detachment issues happen. And also, obviously, we have to be aware of the nuances of the anatomy. Some patients, the AV valve might be too close to the outflow tract, so you can't really deploy something underneath the valve. But also, there are some opportunities for single ventricle patients. And finally, what I've learned during this process is that partnering with our adult structural colleagues is paramount. And it is important because I spend a lot of my time with them doing structural imaging while they do clips for usual anatomy. And that's how I was able to bring this technology to our ACHD patients and for us to work comfortably together to be able to handle those kind of cases. Thank you.